achieving guideline-directed medical therapy, as well as discuss challenges in the management of the advanced heart failure patient and identify strategies to intensify treatment in clinical practice. At the end, there'll be a live Q&A session, so please keep your questions in mind and we'll get to them at that point in the program. Here's our agenda. So we're going to hear from Nasrien Ibrahim on the burden of advanced heart failure. I'll present on where heart failure care stands today. Larry Allen will present on the management of the advanced heart failure patient, and then we'll be delighted to have your questions and answers. So let's kick the program off, and delighted to introduce Nasrien Ibrahim.
Thank you, Dr. Fonarow. That was fantastic. I'm really excited to be here to talk about the burden of advanced heart failure from a patient perspective, from a community perspective, from a caregiver perspective, and also from a health system perspective. These are my disclosures. So I'm going to start with the definition of heart failure. And this is a consensus statement that was just released by the Heart Failure Society of America, the Heart Failure Association, which is connected to the European Society of Cardiology and the Japanese Heart Failure Society. And they define heart failure as signs and symptoms of heart failure caused by a structural or functional cardiac abnormality and at least one of the following: either an elevation in natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. And why is this important? It's important that we have a universal definition of heart failure so we can identify patients in the community that have heart failure, and also for enrollment of patient in clinical trials. It's important that we're actually enrolling patients that have true heart failure in order to ascertain whether or not the therapies we're testing are helpful in patients with heart failure. So I'm going to start with the epidemiology of heart failure. As you are well aware, heart failure is a public health emergency. And by 2030, there's going to be a 46% increase in the Americans living with heart failure. And that's due to an aging population and also a decline in mortality because of the heart failure drugs that we have out on the market. As it remains, every patient that's diagnosed with heart failure, about 50% will die within 5 years. And the cost of heart failure is enormous. So $70 billion is the estimated cost of heart failure in 2030. And as of now, an estimated 6.5 million Americans live with heart failure. And every year, there is 1 million new cases of heart failure. Heart failure is not just a US problem, it is a global problem. And if you look all over the world, especially in Europe, about 4% prevalence in Germany. If we look at the Middle East, we don't have complete data in the Middle East, but in Turkey, the prevalence of heart failure is almost 3%. If we look at Indigenous Australia, about 5.3% prevalence of heart failure. So again, not just an American problem, it's a global burden. When we look at age and its relation to heart failure, the prevalence of heart failure increases with age. So the older you get, the more likely it is that you will have heart failure. In people less than 80 years old, more men than women have heart failure. And at age 80 and above, it switches. So more women at the age of 80 or higher have heart failure than men. But overall, as you age, you are more likely to have heart failure. What about hospitalization and rehospitalization costs? We know these are burdensome on the patients, but also on society. So there's about 900,000 annual heart failure hospitalizations in the United States. And about 20% of patients are readmitted to the hospital within 30 days. If we look at the 5-year data, about 50% of patients are admitted to the hospital within 5 years. So very burdensome on the patients, the caregivers, and also on the healthcare system. When we think about heart failure, we have to remember that it's a chronic disease process. And I like to talk to my patients about this specific figure all the time, because there could be a period of several years when patients feel fine, they feel well, they're able to perform their activities of daily living, they're able to work, they're able to exercise without having any symptoms. And at this time, patients hopefully are optimized on their guideline-directed medical therapies. But there comes a point, because heart failure is a chronic disease, it's a progressive disease, when patients get worse. And the episodes where we describe the patients as getting worse is when they're admitted to the hospital for acute decompensation. They arrive to the emergency department, decompensated, and maybe receive IV diuretics and are sent home. or they are seen in acute heart failure clinics, again, where they're giving IV diuretics and sent home. So every time a patient's admitted to the hospital, it's burdensome, not just on the patient, but also on the healthcare system. But importantly, their outcome is worse. So their long-term outcome is worse the more hospitalizations they get. We like to catch patients here, ideally before the first hospitalization, so that we can intervene, whether we need to discuss advanced therapies like LVAD and transplant, or whether patients need to be optimized on guideline-directed medical therapies. We know there's been 3 classes of guideline-directed medical therapies that have been out for decades, but then there's newer, more novel guideline-directed medical therapies. So this is where patients may need to be optimized to prevent further progression of their cardiac disease. This is also from the consensus statement that I mentioned earlier, and just a quick overview of the different stages of heart failure. So patients with stage A heart failure are patients that are at risk for heart failure. So at this time, they do not have any cardiac or structural abnormalities. They have no elevation in natriuretic peptides or other biomarkers, but they're at risk. So they have diabetes, they may have hypertension, or they may have a family history of familial cardiomyopathy that puts them at risk to develop heart failure. Patients with stage B are patients that do have now either a structural or functional cardiac abnormality, and they may also have an elevation in biomarkers, specifically natriuretic peptides, that tell you that the myocardium is stretched. So these are patients that have structural or cardiac abnormalities, but do not have any symptoms of heart failure. What's pertinent to us in this talk today is patients with symptomatic heart failure. So now patients are stage C once they develop symptoms of heart failure. Either they've had symptoms in the past or they have current symptoms of heart failure in addition to the structural or functional abnormality. Sometimes patients with optimization of their guideline-directed medical therapy no longer have symptoms, and we call such patients heart failure in remission. And some patients have persistent heart failure symptoms, and we call these patients persistent heart failure. And so when we think about going from stage C to stage D, and stage D is what we call advanced heart failure. So these are patients who have failed guideline-directed medical therapies because they continue to have symptoms. Maybe they have recurrent hospitalizations, and despite everything we've done with guideline-directed medical therapies, or maybe they don't tolerate guideline-directed medical therapies, they continue to have burdensome symptoms, and we have to talk now about advanced therapies such as LVAD or transplant. However, we should think about advanced heart failure as also the patients in stage C that continue to have symptoms despite optimization of guideline-directed medical therapies. These are the patients that should be seen by an advanced heart failure cardiologist, because we want to ensure they're A, on the appropriate guideline-directed medical therapies, but B, are they optimized? Are they on the appropriate doses of guideline-directed medical therapies? And can we help with just medical therapy relieve some of their burdensome symptoms? So important to note, sometimes we meet patients that are sent to us for evaluation for transplant and LVAD, but once we review their guideline-directed medical therapies, we realize that there is room for optimization, and so we don't call them stage D, we call them again stage C. So when I think of advanced heart failure, I think of patients that have burdensome symptoms that interfere with their activities of daily living and really interfere with the things that they love doing or they're able to do on a regular basis. So symptoms is signals for advanced heart failure. So when we think about the progression from stage C to stage D, these are patients that have increased symptom burden. They have reduced functional capacity. Again, they're not able to do the things they were able to do months ago. And these are patients that have frequent hospitalizations. And as a reminder, the more hospitalizations a patient has, the worse their long-term outcome. And what can we do? Important to note whether or not patients are optimized on their guideline-directed medical therapies, whether there's room to add the more novel therapies, or if there's room to optimize the current therapies that they're on. And then important to note whether or not patients are candidates for cardiac resynchronization therapy or procedures like percutaneous mitral valve, so to improve symptom burden. So this is one of my favorite mnemonics, and it's WENTR for patients to an advanced heart failure cardiologist. And I look at this as it's not a failure of the therapies that you were able or you tried to provide a patient. This is just A heart failure cardiologist may have little tips and tricks of how to optimize guideline-directed medical therapies, especially the more novel therapies that not many people are very used to working with right now, or when we need to discover whether or not a patient needs to go be evaluated for transplant or VAD. So I is for IV inotropes, and the mnemonic is I need help. N is patients with persistent New York Heart Association class 3B or 4 symptoms, or they have persistently elevated natriuretic peptides, because an elevation in natriuretic peptides can mean consistently volume overloaded, or it can mean an infiltrative process. E, end-stage organ dysfunction. And so the concern here is we want to meet patients before their creatinine gets to the point where we now have to consider them for a heart and kidney transplant, or now that they're no longer an LVAD candidate because now they require dialysis. Ejection fraction less than 35%, patients who've had defibrillator shocks, patients that have had frequent hospitalization, so more than one hospitalization in the last 12 months, patients that continue to be edematous despite escalating diuretics, patients with low blood pressure and high heart rate. And high heart rate should be a red flag. It's concerning because the heart's trying as much as it can to increase cardiac output. And so you see the heart rate going up, that tells us the heart is sick and the patient should be seen by an advanced heart failure physician. And then lastly, when you have to down titrate guideline-directed medical therapies, either if you have to down titrate or stop, this is also a red flag that patients are sick and should be seen by an advanced heart failure cardiologist. I'm going to spend a little bit of time talking about disparities in heart failure. And if we look here, it's important to note that Black patients are significantly more likely to develop heart failure, and heart failure presents earlier than Hispanic and white patients, and also the patients present sicker. So again, patients present early and with a higher disease burden. If we look at hospitalization rates, so Black patients have a higher hospitalization rate than Hispanic patients and white patients. But it's also important to note that the hospitalization rate of Black patients is 2.5 times their white counterparts. And why is that important? Because as I mentioned, the more hospitalizations a patient has, the worse the long-term outcome. If we look here at the rates of cardiovascular death, so in patients less than 65 years of age, Black men and Black women have higher cardiovascular death rates compared to white women and white men. And if we look above the age of 65, it's mostly in men. So Black men and white men have higher cardiovascular death rates compared to white women and Black women. And why is it important to note here the difference? So in a lot of times when we decide on advanced therapies like LVAD and transplant, these decisions are usually made in younger patients. So with Black men and Black women having higher rates of cardiovascular death in this age group, then we would expect them to be transplanted more often and given LVADs more often, but this is not the case. When we look at guideline-directed medical therapies, it's the dosing and titration of guideline-directed medical therapies is really suboptimal regardless of race or ethnicity. And Dr. Fonarow will talk to you a little bit more about how suboptimal GDMT implementation is, but it does not vary across race or ethnicity. When we look at devices, this is data from American College of Cardiology's NCDR registry, and Black and Hispanic patients that are eligible for CRTD are less likely to receive CRTD compared to white patients. When we look at advanced therapies like VAD and transplant, there has been an improvement in VAD and transplant rates, but the rates are still below what is expected for the high disease burden in Black individuals. And still, for reasons that many are trying to discover, that Black patients still have higher post-transplant mortality than white patients. What about enrollment in clinical trials? So Black patients continue to be underrepresented in clinical trials. And we know that Black patients have a higher incidence and prevalence of heart failure, but are still underrepresented in trials. This is data showing that over the last few decades, there has been an increase in enrollment of non-white patients, but yet still less than half of clinical trials have race and ethnicity data reported. And why is that important? Because our clinical trials really should represent the demographic that has that specific cardiovascular disease process. In this case, it would be heart failure. We want to create drugs and therapies and devices that really treat the population that has this disease burden. So what contributes to the disparities? There's many things that contribute, both individual and societal factors. When we look at healthcare system and policy factors, we look at things like insurance access, access to cardiovascular clinicians that have expertise in advanced heart failure, use of guideline-directed medical therapies, workforce diversity. And then we look at environmental factors. When you look at neighborhoods that have food deserts, so limited access to healthy foods makes it more likely for patients from those communities to have higher disease burden. Cardiovascular risk factors like obesity and diabetes are higher in those communities that have less access to gyms and healthy food options. So many contributors to these disparities. And what can we do about these disparities? Well, we can do something at really every level in society. So from a public policy level, broadening insurance coverage, improving financial access to the guideline-directed medical therapies, but especially novel therapies. Sometimes even with insurance coverage, the copays are unaffordable to many patients. A community-wise efforts, improving access to healthy foods, improving access to cardiac rehab. Sometimes cardiac rehab is an hour away from some of these communities, which makes it really burdensome for patients to engage in exercise. Organizational things that can be undertaken include implicit bias training. For clinicians, we all like to say that we have no biases, but we all certainly do. And we could use implicit bias training on a regular basis to make sure that we're not contributing to these disparities. And then social support. Social support becomes really important, especially when we make decisions about things like LVAD and transplant. And then from an individual perspective is improving prescription of guideline-directed medical therapies, but adherence and finding out why patients are having trouble either staying on the medications or even getting access to the medications. And very important is improving participation in research and clinical trials, because we want real world data. We want to know how patients from all sorts of socioeconomic backgrounds are, participating in the trials, how they're taking the medications, how the medications are affecting them. So it's really important to have representation across socioeconomic status, but also race and ethnicity. And then, of course, most important is patient-centered education and decision-making, especially when you're introducing new medications that are more costly than older medications and device therapies to patients. So in summary, heart failure is associated with significant patient burden, including frequent hospitalizations and readmissions. Heart failure is a progressive disease that requires advanced heart failure cardiologists to aid in patient management. And I would say when the patients start to have symptoms and you're concerned that now it's advanced heart failure, or you're having trouble with optimization of guideline-directed medical therapies, or you're just unsure where to go next, it's always important for the sake of the patient, also for yourself to not feel uncomfortable, is to refer patients for advanced heart failure cardiology management. And then finally, disparities in heart failure outcomes persist, particularly in Black patients. And there's a variety of individual and societal factors at play. And we need to attack those at every level in order to dismantle these disparities. So I will stop here and I'll hand this over to Dr. Gregg Fonarow.
Thank you for that excellent presentation, Nasrien. I'll now present on where our heart failure care stands today. Here are my disclosures. Now, the importance of current treatment was highlighted by Nasrien regarding the burden of heart failure being common, costly, and by natural history deadly. This slide further illustrates how when individuals develop heart failure, the impact it has on their survival. Compared to the median survival for the general US population, age 65 to 69, having heart failure means a 15-year loss of life, and illustrates why it's so important to apply our evidence-based guideline-directed medical therapies when they are available to address this tremendous burden that patients face as far as loss of life. Fortunately, we have a number of evidence-based guideline-directed therapies that have been so powerful in clinical trials they actually can reduce all-cause mortality. This slide shows those therapies that provide the foundation of our guideline-directed medical therapy for heart failure with reduced ejection fraction. The angiotensin receptor neprilysin inhibitors, evidence-based beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. When we look at the clinical trials summarized in this slide, we can see a very substantial reduction in all-cause mortality with these therapies in relative risk. When we look at it in absolute terms, the number needed to treat to save a life over 36 months, very low numbers, and that these therapies also significantly reduce hospitalizations and rehospitalizations for heart failure. When we look at how these are applied in clinical practice, though, it's often as if clinicians do not truly view these therapies as additive to each other, that patients may be on one or two of these medications, but not necessarily the full set, raising the question of whether these therapies truly are fully additive to each other, that there's incremental benefit, or are they somewhat redundant or partially additive? Can we answer that important question from the randomized clinical trial evidence? And the answer is yes. We know that ACE inhibitor and ARB therapy compared to placebo reduced all-cause mortality. When we look at patients already on ACE inhibitor or ARB therapy in the addition of one of the evidence-based beta blockers compared to the addition of placebo, we see this incremental mortality reduction of 34 to 35%. So truly additive benefit. When a patient is on an ACE inhibitor, ARB, and a beta blocker, is there additive benefit with the mineralocorticoid receptor antagonist? We see in Rawls' trial where there was high ACE inhibitor use, but relatively low beta blocker use, mortality reduction. But the more recent emphasis HF trial in mild heart failure, even with high background use of ACE inhibitor and ARB and beta blocker, this incremental mortality reduction, truly additive. In the case of neprilysin inhibition, when this is added to background RAS therapy, we also see benefit. This is from Paradigm HF trial, where we see compared to ACE inhibitor therapy, the use of valsartan combined with the neprilysin inhibitor sacubitril, this incremental reduction in cardiovascular death and all-cause mortality. So that compared to being on an ACE inhibitor or ARB alone, being on the angiotensin receptor neprilysin inhibitor, this incremental benefit of an additional doubling of the cardiovascular mortality reduction in relative terms. So again, this incremental and additive benefit. The newest class of drugs for heart failure with reduced ejection fraction that reduced all-cause mortality is the SGLT2 inhibitors. This work came out of the clinical observation in the cardiovascular outcome trials with SGLT2 inhibitors studied in patients with type 2 diabetes, where there was a remarkable finding of lower risk of being hospitalized for heart failure or cardiovascular death in patients without pre-existing heart failure. And that was tested in the DAPA-HF trial, randomized 4,744 patients with heart failure with reduced EF and other standard background therapy to the SGLT2 inhibitor dapagliflozin 10 milligrams once daily versus matching placebo. And what this trial showed overall for the primary composite endpoint, clear benefit. But importantly, for the 55% of patients in this trial with no type 2 diabetes, there was similar benefit in relative risk reduction to those with type 2 diabetes and no significant interaction. So truly a therapy for heart failure with reduced ejection fraction to improve clinical outcome. Emperor Reduced showed comparable findings, and we now have a meta-analysis as published in Lancet with these two major trials showing the totality of evidence demonstrates when added to standard background therapy, a reduction in all-cause mortality, cardiovascular death, and hospitalization for heart failure. And importantly, these therapies truly additive to the other standard background therapies. Importantly, this therapy was well tolerated compared to placebo with a serious adverse event rate leading to discontinuation similar to placebo. More recently, we have the Victoria trial that looked at the vericiguat, the oral soluble guanylate cyclase stimulator, and this was in patients who had had a prior heart failure hospitalization. There was strong background medical therapy use, but SGLT2 inhibitors were not yet in use. And you can see here, there was a more modest treatment effect with this class of therapy. It did meet its primary composite outcome, but no significant reduction in cardiovascular or all-cause mortality. So how should we apply these foundational guideline-directed medical therapy? What should the sequence be? Should it follow the historic sequence of the randomized clinical trials and their discovery, or should we have a more expedited approach? And the critical question here is, how long does it take to see benefit? If it takes months or years before patients accrue clinical benefits, maybe a drawn-out sequencing would be appropriate. But as this slide shows, that we have this very substantial early reduction in all-cause mortality. In Copernicus, with the beta blocker carvedilol, we have this significant benefit within 2 weeks. In Emphasis, within 30 days, highly significant reductions in clinical events. In Pioneer, in hospital initiation decompensated heart failure, is better to go with an ACE inhibitor first and then later switch to sacubitril/valsartan, or sacubitril/valsartan up front. Very early benefit, first 30 days over the first 8 weeks, 6% absolute risk reduction. And the SGLT2 inhibitors, all of the trials showing significant benefit in the first 2 to 4 weeks. So delay of therapy means clinical events that could have been prevented. So a simultaneous or rapid sequence strategy is going to allow us to get patients the early benefits from each of these foundational therapies. So starting the low recommended heart failure doses as soon as patients are hemodynamically stabilized of sacubitril/valsartan, beta blocker, MRA, SGLT2 inhibitors, the starting dose that requires no titration, focus over time on the up-titration of beta blockers, and our patients thus can derive, by a rapid initiation of the complete set of comprehensive disease-modifying medical therapy, these early and long-term benefits, but may also have the added benefit with this upfront strategy of enhancing adherence, compliance to therapy, as well as these early benefits. So this slide highlights the benefits of initiating our quadruple therapy as first line rather than a more drawn out sequencing. We can get rapid improvements in health status, rapid improvements in EF, such that a patient may not require a CRT or ICD because their ejection fraction is now above 35% in that first 12 weeks. Rapid reduction in heart failure hospitalizations and rehospitalizations, the rapid reduction in mortality, and importantly, an improved use, adherence, persistence, and overcoming clinical and therapeutic inertia. And this slide illustrates how in clinical practice, how strong therapeutic and clinical inertia is. The majority of patients in current US practice, despite guideline recommendations, despite the evidence, are predominantly managed with ACE inhibitor ARB and a beta blocker, not on an MRA, not switched to sacubitril/valsartan, not on an SGLT2 inhibitor. And many are at much lower doses than were shown in the trials and recommended in the guidelines. We can overcome this clinical inertia, and if we do, we'll substantially improve clinical outcomes. This is data from Pinnacle showing the similar type of data. Majority of patients, ACE inhibitor ARB and beta blockers, still even treatment gaps there, but not on comprehensive disease-modifying medical therapy. What are some additional strategies for facilitating initiation, in-hospital initiation in hospitalized patients? Use of performance improvement systems like Get With the Guidelines, Improve HF, and others. Multidisciplinary heart failure disease management programs. Use of specific navigators or PharmDs to guide the guideline-directed medical therapy. Specific clinics, telehealth, digital health tools, and patient activation such as Dr. Allen's EPIC HF program. Now, what about the financial burdens of heart failure as well as the medications? So if we look at the cost of heart failure, they're high and are going to continue to arrive over time as more and more patients have heart failure. So the disease state itself is quite expensive. We can counteract so much of the cost that's driven by heart failure hospitalizations with our evidence-based medical therapy. Now, of course, two of these medications are generic and very low cost and are highly cost effective, is not outright cost dominant. Two of these, however, are branded medications and do have higher costs. But if we look at the formal cost effectiveness, offer higher intermediate value. But yet patients often have significant out-of-pocket expenses. So it is a legitimate question whether it's worth it for the patient to have these out-of-pocket expenses and whether it's worth it for the clinician to go through the extra efforts around prior authorization and help assist patients to be able to get on these medications and maintain adherence. So when looking at what the impact is on median survival in years of life that patients can get back, we compared the expected outcomes from the randomized trials, the actual observed data of being on what was the prior conventional therapy, ACE inhibitor, ARB, and a beta blocker, versus being on comprehensive therapy, being on sacubitril valsartan instead of an ACE inhibitor, ARB, adding that MRA, and having an SGLT2 inhibitor. And with those steps, this added a median of 6.3 years of life. So patients with heart failure with reduced ejection fraction can have 6.3 years extra life on average when treated with comprehensive versus prior conventional therapy. I would argue strongly that it is worth it to apply these therapies comprehensively. So we should be reimagining our heart failure care for these patients, take advantage of learning health systems and applying our evidence into routine clinical practice, take advantage of implementation science, identifying barriers and overcoming them, and some examples in precision medicine with the ultimate goal here of improving the healthcare and health systems with high value by taking advantage of the remarkable advances with our guideline-directed medical therapies for heart failure with reduced ejection fraction. So to summarize, the benefits of our evidence-based medications are truly additive and incremental. No substantial overlaps have been demonstrated for the four foundational medical therapies for heart failure. The optimal approach is to employ quadruple therapy immediately to reduce all-cause mortality unless contraindicated or patients are known to be intolerant to treatment. A more serial selective approach leads to delays and heart failure hospitalizations and deaths that could have been prevented with earlier and more comprehensive use of our evidence-based therapies. And then for select patients, of course, additional therapies, devices, and other considerations will be important. Thank you so much for your attention. Let me now turn it over to Dr. Larry Allen.
Well, thank you, Dr. Fonarow. And this is Larry Allen from the University of Colorado. And I now have the pleasure of concluding these sessions with the management of patients with advanced heart failure. I think a good way to summarize this is everything should be made as simple as possible, but not simpler. And our goal here is to take a pragmatic approach to how to actually get these therapies applied to our patients in ways that they can handle. These are my disclosures. So as was nicely summarized by Dr. Fonarow, guideline-directed medical therapies generally have additive benefits such that the relative risk reductions applied to patients with HFrEF come together to produce very marked reductions in hospitalization and mortality when used in combination. However, guideline-directed medical therapies are also additive in terms of their burden. So you can see on the far left side, we now have a large number of therapies that have been shown to improve the health outcomes of our patients. But many of them reduce blood pressure, they can reduce heart rate, they can decrease glomerular filtration, they can affect potassium in different ways, and then they can cost not only society, but individual patients in terms of out-of-pocket costs. And these come together to create significant burdens in certain areas for certain patients. This is amplified in patients with advanced heart failure. So as Dr. Ibrahim showed nicely, the I Need Help acronym can tell us about signs of the transition to stage D heart failure in our patients. But not only do we recognize that our patients are now having problems and need special attention, but this often leads to de-escalation of guideline-directed medical therapy and challenges in the use of the therapy because of intolerance of neurohormonal antagonism, as well as effects on renal function. This is further complicated because the majority of our patients with heart failure have multiple major chronic conditions. You can see that the minority of people have 0 or 1 other conditions in addition to heart failure. The majority have multiple chronic conditions, and many of them have up to 6 additional medical problems that are being managed at the same time. And this increases as patients get older and also suffer from frailty. Therefore, adequate control of heart failure requires good management, not only of heart failure itself, but of the multimorbidity of these patients that not only affects their health, but affects their cardiac function, including glucose control, renal function, blood pressure management, AFib, stroke and rate and rhythm management, lung function, etc. Coming straight from that multimorbidity is that heart failure treatment is associated with polypharmacy as well. On the left, you can see a very recent article that showed that the majority of patients with heart failure and reduced ejection fraction now have to take an average of 10 or more medications, different medications per day. And on the right, you can see that as patients' multimorbidity rises, the number of medications that they take increases rapidly, primarily due to non-cardiovascular medications they're taking on top of their guideline-directed medical therapies. So as we think about how to treat advanced heart failure with reduced ejection fraction, I think this is what it looks like for patients, but it's increasingly looking like this for clinicians of all sorts. So I think one of the main ways forward is to think about value. Value to me is the most important word in medicine. Value is defined as the quality of care over the cost of care. A way to think about this for when we're treating patients is what are the outcomes, the health outcomes of our patient, plus the patient experience that they're having in dealing with the health system, divided by the direct costs and the indirect costs of the care that they're receiving for those medical problems. In heart failure, again, we have many therapies that provide quality in terms of benefit in survival and quality of life for our patients in terms of their health status measures. But this is balanced against the side effects, the hassle, the interactions of various treatments, and the out-of-pocket costs that our patients face when they engage these therapies. So this is a summary of the high quality data we have in heart failure with reduced ejection fraction. It defines those many therapies that are evidence-based medicine for HFrEF. And the point of this slide is to show that it's not only difficult to keep up on the various trials and the nuances and how they apply to our individual patients, but the sheer number of therapies has become complicated. And so we have obviously tried to simplify this by focusing on those therapies which appear to have the greatest value. And this has resulted in what we call the pillars of guideline-directed medical therapy, or what people are increasingly talking about in terms of quadruple therapy or quad therapy for HFrEF. I like to think of this as not only the ARNI, beta blocker, MRA, and SGLT2, but that alongside of good volume control, primarily with a loop diuretic. And so if we have our patients euvolemic so that they're not congested, and then we combine that with each of these 4 therapies, which provides around a 30 to 35% relative risk reduction, we can make huge gains in our patients' health outcomes over time. And again, when you put these together, we're providing significant extension of life and the quality of that life that our patients are leading. Once we accomplish the high value therapies, then we can move on to additional heart failure therapies that may provide either lower value but value benefit, or that may particularly apply to unique patients or patient populations, such as hydralazine isosorbide for patients that are African American or have particularly high blood pressure, ivabradine for patients who have sinus rhythm with tachycardia that is either unresponsive or unable to tolerate beta blocker therapy, vericiguat in patients who have been maxed out on these other therapies and continue to be at high risk for hospitalization, and then a number of device therapies which also have strong evidence base in specific populations, particularly cardiac resynchronization in those patients with wide left bundle branch block. So again, value is not just the benefit, but thinking about the side effects and intolerance of the therapies that we prescribe. So when we look at the medical therapies that we apply, they have effects that are additive on blood pressure, heart rate, renal function, potassium, out-of-pocket costs to our patients, and the total regimen complexity. And our patients are each different, where they have reserves in each of these areas that are accessed differently by the therapies that we prescribe. So we've started thinking about this in terms of a heart failure spending function, where each patient has spending accounts. They may have a lot of blood pressure, but very little heart rate. And in a patient like that, the use of a therapy that's a vasodilator, like sacubitril/valsartan, may be more appropriate than a beta blocker. Similarly, our patients who do not have good insurance coverage for medicines that are not yet generic may have significant challenges around out-of-pocket costs, which would favor medicines that are less expensive to them. So when we move to sequencing, there are a number of ways to think about prescribing these drugs to patients with a new diagnosis of heart failure. The conventional sequencing is on the left, but this leads to getting patients on therapy over the course of not just weeks, but months. And so people have proposed faster sequencing mechanisms to get patients onto therapy sooner, as was highlighted by Dr. Fonarow. This is one example proposed by Drs. McMurray and Packer. But I think that sequencing really does, again, need to think about the individual patient and the challenges that they have. So a patient who is started on loop diuretic and is having hypokalemia should probably have their mineralocorticoid receptor antagonist started immediately in the hospital, as Dr. Fonarow suggested. And the Athena trial would argue that this is safe. Additionally, our patients who have no medication coverage from their health insurance and have limited income probably can't tolerate the costs of SGLT2 inhibitor and ARNI, and thus may have a different sequencing that fits them better. Therefore, I like this figure from the recently updated 2021 expert consensus decision pathway from the ACC, which talks about for patients with stage C HFrEF, how to go through these different nodes in thinking about all the therapies that are important for them that potentially have high value, but to sequence them in a way that makes the most sense for them individually. And again, this concept of talking about out-of-pocket costs to patients is important. We did a number of interviews recently with patients as well as clinicians and manufacturer, and what we found was significant discordance on the way people think about talking about out-of-pocket costs. Our patients felt that out-of-pocket costs are crucial to their decision-making and are important to put in perspective of their total healthcare costs as well as their non-medical expenses like their mortgage payments. Interestingly, physicians and the manufacturer did not share this perspective from the patients and felt that really emphasizing the health outcomes in terms of hospitalization and mortality was the primary concern, and even discouraged these cost considerations and discussions. And we feel that this may contribute to the non-adherence that is seen sometimes in patients with HFrEF on these therapies. We think that adherence to the regimen and understanding what patients face day to day is really critical. So we developed decision aids in our research group and developed a decision aid for sacubitril/valsartan. Interestingly, when we think about the benefits and then the burdens of sacubitril/valsartan therapy, the benefits have been well outlined, but the burdens are really not so much around side effects, maybe a small increase in hypotension, but they're really about the out-of-pocket costs that our patients face. And so this decision aid spends a lot of time on helping patients understand what their level of insurance coverage is when it comes to medication costs, how they can consider reducing their costs through assistance programs, coupons, and other options potentially, and then how they can work with their insurance company or with their clinician and their pharmacy to get estimated out-of-pocket costs for themselves. And then once thinking about the benefits and the costs that they face, then deciding through a values affirmation exercise whether it's worth it to them to pay those extra costs to switch over to the higher benefit drug. So I think this exercise of really relying on patient values for these kind of decisions is important. One of the ways that we talk about shared decision-making is to use this idea of a spectrum of the way that we work with patients to make medical decisions. So on the far left, we can just let patients make their own decisions, but to some extent they need our help and they need our advice around where the highest value therapies lie. And so just saying you can do what you want is really abandonment. But on the right, if we tell patients what to do, not only is that paternalism, but it probably doesn't appreciate the other things in their life that are important to them, that are challenging to them and may color the way that they make their medical decisions. And shared decision-making is in the middle here, where we consider this to be a meeting of two experts, where the patient is an expert on their values, hopes, and fears, and the clinician is the expert on what options are medically reasonable, what are the best, worst, and likely outcomes for each option, and thus what seems to provide the highest value. And this leads to a dynamic discussion. Unfortunately, there's a lot of inertia out there when it comes to guideline-directed medical therapy. Dr. Fonarow showed you the CHAMP data from hundreds of sites in the United States looking at guideline-directed medical therapy. This is a study that we did called Epic Heart Failure, looking across our health system in the state of Colorado. And just like CHAMP, it shows that most of our patients are on a beta blocker, but not near goal dose. Very few of our patients are actually on sacubitril valsartan. About half of our patients are on spironolactone or eplerenone. And then other non-quad therapy treatments are also used infrequently. Interestingly, we had 300 patients in this study, and there were no patients who were receiving target doses of evidence-based beta blocker, ARNI, or MRA combined. So we developed a tool called Epic Heart Failure, which was designed to activate patients immediately before they had a clinic appointment with their cardiologist. This involved a 3-minute video, which was really designed to motivate patients and ask them to be engaged in the clinic visit. And then it came with a 1-page checklist that they were asked to print out and bring to the visit to review their medicines that were prescribed to them against best medical therapy. And the hypothesis is that activating patients, empowering them to engage their clinicians would prompt greater HFrEF prescribing and intensification of these therapies. We ended with, remember, you are the person who knows you best. You have the most to gain by being on the best medicines possible. You have a right to ask questions about your own care. And so really try and make at least one positive change during the appointment rather than just saying things seem to be going well, let's move on. And what we found is that we met the primary endpoint, which was a significant increase in prescription of GDMT in the patients who received the activation tool. So in those patients who didn't receive the tool, 30% of the time they had their guideline-directed medical therapy increased. And with just getting a prompt to open this 3-minute video and look at this 1-page checklist, we saw a 20% absolute increase in the number of patients who had their drugs intensified. So in summary, evaluation and management of patients with advanced heart failure are challenged by higher levels of medication intolerance, polypharmacy, multimorbidity. And clinicians cannot ignore these issues, or heart failure treatment will fail because patients cannot manage it without a thoughtful, individualized approach. Treatments that have the highest value for our individual patients should be employed first. Remember, value is the expected benefit relative to the risks, burdens, and out-of-pocket costs. And this is different for each patient. And so sequencing of therapy should be aggressive. It should start early, but it must also be individualized and thoughtful. consider spending and employing shared decision-making, including formal patient decision aids, to iteratively tailor heart failure management and overcome inertia with a proactive bias to do something. Engage your patients, get them involved, ask them to share their concerns, and then make a positive change in their guideline-directed medical therapy. Thank you.
Thank you, Larry, for that excellent presentation. We'll now turn to audience question and answer. We'll be delighted to answer any questions you have. Please utilize the chat box that has appeared to